and more. And in this portion of our presentation, we'll be talking about cardiomyopathies as well as cardiac transplantation. These are some of the diagnostic studies that we can use when we are caring for patients with heart failure, as well as some cardiomyopathies. Again, it's the chest x-ray. The chest x-ray gives us valuable information in terms of the size of the heart and as well as any kind of cardiomegaly enlargements, and can be detected especially if we look at the cardiac silhouette. EKG, again, for any electrical conduction issues that can arise as a complication of these structural changes in heart failure, and also the echocardiogram, which is the use of sound waves to detect alterations in structure and function of the heart. Hemodynamic assessments are used as well, especially in terms of pressure measurements and assessments inside the heart. We will look at measuring pressures within the left ventricle, for example, and those increased pressures would be found with heart failure. And we have stress testing. We'll talk about each of these. We have both exercise and chemically induced stress testing. And we have cardiac catheterization. That's where we have the advancement of the catheter through the vasculature up into the coronary arteries, where we can identify lesions and also intervene with the angioplasty and stent placement. The ejection fraction can be obtained. A rough estimate can be obtained through an echocardiogram. Again, greater than 55% or so is normal. And we have other diagnostic studies that we can use to get a more accurate assessment of ejection fraction, such as the MUGA scan. We also have serum BNP levels that can be measured, and they are helpful in differentiating between heart failure and pulmonary disorders. Remember, the heart failure patient often present with shortness of breath and dyspnea. So we need to differentiate whether or not the shortness of breath is due to heart failure or is it due to a pulmonary disorder, perhaps pneumonia, bronchitis, or something to that effect. And one way we can do that is by measuring the BNP, because this is a hormone that is secreted by the ventricle when it is overstretched in heart failure. Okay, so we can find out if that is elevated. If the BNP comes back as elevated, then we know that the source of the shortness of breath is truly a problem with the heart. Okay, we're not going to have an elevation in BNP if there is a pulmonary disease that is responsible for the shortness of breath and respiratory symptoms. Echocardiography is a non-invasive test that uses ultrasound to evaluate cardiac structure and function. It may be done following exercise to evaluate movement of the myocardial wall and assess for possible ischemia or infarction. And this picture shows you, for example, that there is an enlargement in the left ventricle. On the actual echocardiogram, we see on the right side of this slide that the left ventricle is enlarged, it's overstretched. So that is information related to structure of the heart, and confirms that the patient has heart failure. So the echocardiogram is used to evaluate left ventricular function, not just structure, but also how does the left ventricular wall move? Is it hypokinetic? Is it the movement been altered and impacted by the overstretching? So we can look at that movement of the wall and assess if the patient has had any heart attack, for example, ischemia or infarction. Coronary angiography is another diagnostic tool, and it is the most accurate indicator of coronary heart disease. And in this particular picture, you see when they inject the dye into the coronary arteries, we can visualize any lesions that are there. In the first picture on the left, we see two white arrows pointing to the lesions or the occlusions that impair blood flow to the myocardium. In this particular example, they're actually showing that there are lesions in the circumflex artery as well as the LAD. And then they place stents, and then you can see afterwards where the white arrows are that the patient will experience immediate relief of their chest pain, and absolutely at least 80% resolution occurs in the ST segment elevations. In other words, that resolves the issue of the ST elevation once they get perfusion to the tissue again. Okay, now remember the complications of having a coronary angiography performed, because they have to go in through the groin. Most of the time it's the groin, although it can be done in the arm. And the problem with that is as they advance the catheter all the way up into the coronary arteries, there is a risk of developing a hematoma at the insertion site following the balloon angioplasty procedure. So it is one of those important things for the nurse to implement, is having the patient prevent bending or flexing of the leg on the affected site of the angioplasty. So certainly in that area, the percutaneous, where the catheter was inserted in the groin, that area, the number one complication of this procedure is bleeding. And so it's very important for the nurse to implement the measures of preventing flexion of the leg on the affected side. Now, the affected side the patient should actually lay in bed for approximately 4 hours to make sure that the clot has taken and that there isn't going to be any more bleeding. Of course, you will follow the protocol in your facility, but around 4 hours, I believe, is the amount of time that they recommend for laying flat without bending the leg. Nursing care for the patient with heart failure. When they are in the hospital, they are going to be on bed rest, okay, because their heart is already struggling to meet their normal demands. And if we have them up and exerting themselves, that's going to put increased oxygen demand on the heart. And so we also want to give them supplemental oxygen therapy, anywhere from 2 to 6 liters, depending on their needs. And all the drug therapy that we have to monitor and administer to the patient and educate the patient about the drugs that they are receiving. Daily weight, highly important in the hospital and at home. because those weight gains, 2 to 3 pounds overnight, that's a problem, because that is fluid that is just building up in their lungs. So also sodium restriction is important, because where sodium goes, where salt goes, water goes and follows. So we have a sodium restricted diet for these individuals. And because they're frequently on diuretics such as Lasix, they may also have a Foley catheter, because they'll be voiding a lot, and especially at night we don't want them waking up and walking to the restroom and increasing their risk for falls. We must monitor the intake and output very closely with our heart failure patients. Okay, we don't want them to have excessive volume intake or be in a fluid volume excess situation, because that fluid is increasing preload, increasing the work on the heart that's already struggling, and it will simply back up into other areas where it doesn't belong. We've talked about many of these drugs already, so I'll just list them. Drug therapy may include, for our heart failure patient, ACE inhibitors, diuretics, digoxin, nitroglycerin, and beta blockers we see at the bottom. We've talked about all of those before and how they work. I just would like to mention this beta blocker here called Coreg, or carvedilol. It is both an alpha and beta blocker. We use it very commonly in our heart failure patients. It is an extended release beta blocker medication, and it's used to treat mild to severe heart failure and high blood pressure as well. It relaxes the blood vessels and it slows the heart rate, allowing the heart to work more efficiently. And there's another beta blocker there called metoprolol, and that also can come in as an extended release form. Now, the one that we have not spent much time on is Natracor. This is a human B-type natriuretic peptide, or naseritide. Natracor is the brand name. Another brand name of a very same medicine is Primacor. So you can see here of and use both of these in the hospital. Natracor or Primacor is a BNP. Remember, we said that the BNP is a hormone that's secreted by the left ventricle when it is stretched. And the reason why is because inside the body, that BNP will assist or aid the left ventricle to constrict stronger, so to improve contractility. That's the benefit of that hormone in the body. Well, scientists decided, if this is such a wonderful chemical, then let's make it in the laboratories and package it as a drug and give it in a higher dose. And that's exactly what they did. So BNP, Natracor is BNP. That's what it is, but it's a higher dose, and that we can administer it to our patients in heart failure to improve the contractility of the heart. Okay, so here is a picture of a patient who is receiving his drip of Natracor. It is infused. It can be a continuous infusion. As we said, it does lower blood pressure, so we would want to monitor the patient's blood pressure. And it also allows for improved efficiency of the heart. It causes a lot of the arteries and veins to relax, causing better blood flow for the heart. And so it is used to improve breathing in people with congestive heart failure. Okay. And in this picture, I want you to realize that this person is in an end-stage heart failure. stage 4 or class D of heart failure, depending on which scale you use. So this drug really is reserved for our late stage heart failure patients when we've already exhausted all of those other means of improving their efficiency of their heart. Morphine sulfate is another drug that we use quite frequently with heart failure patients because it affects the smooth muscle, again causing relaxation of the smooth muscle and promoting better oxygenation. It also has the benefit of relieving anxiety, which reduces oxygen consumption. Okay. Also, it does provide pain relief. Digoxin, or digitalis, is a positive inotropic agent. We use it to increase the force of the contraction in our heart failure patients. It also acts to decrease the speed of conduction through that AV node. It is referred to as a negative chronotrope because it slows down the speed of the electrical conduction through the heart. By slowing down the speed of the conduction, it allows for more complete emptying of the ventricles. Now, digoxin has a very narrow therapeutic range. When it's above the normal level, it can become toxic to the individual. And certainly when it's too low, below the normal range, then it is no longer therapeutic for that individual. The normal range is shown here, 0.8 to 2.0 nanograms per milliliter. You need to memorize this level, the toxic level. A dig of greater than 2.4 nanograms per ml is considered toxic. And we will now talk about the signs and symptoms of toxicity, dig toxicity. The early symptoms are nausea and vomiting and anorexia. In other words, kind of GI symptoms. But one that we need to be familiar with are visual changes. Changes in color perception. Okay, sometimes they may see a yellow-green distortion, but other color distortions occur as well. Also, they can see halos and bright spots, blind spots, blurred vision. Any type of visual disturbance can be an indication that the patient is becoming toxic with their dig. Arrhythmias are also a symptom of dig toxicity. We can have irregular pulse. We can have bradycardia, very slow heart rates below 60 beats per minute. We can have, as we see here, premature ventricular contractions. The patient may feel palpitations. We can even have the development of atrial fibrillation and first-degree heart blocks. So arrhythmias are also a common symptom of dig toxicity. Now, two very important concepts on this slide regarding dig toxicity. One of them is related to potassium levels. Low levels of potassium in the body increase the risk of dig toxicity. Well, what about our heart failure patients? Are they likely to be hypokalemic? Yes, because frequently they are on Lasix. And that can actually deplete a patient's potassium. So our heart failure patients who are taking dig may also have low potassium, and the two together can potentiate arrhythmic effects. Okay, so that's something that we have they love to test you on that. They want to make sure that you understand that when it comes to taking care of our heart failure patients on DIG. And the other thing is kind of a generality that's important to realize when we're taking care of patients. When there is any dysfunction of the kidney or liver, that can interfere with drug metabolism. Okay? So it's not only our patients who have kidney or liver disease, but also our older adults. Because as we age, there are normal changes in the functioning of our kidneys and our liver. As a result, they do not metabolize these drugs as quickly or as much as they used to. So they have a real possibility of building up in the bloodstream. So again, we have to be careful with this population of patients if they are taking digoxin. So reduced kidney function will cause digitalis to build up in the body rather than be removed normally through the urine. Certainly, if your patient's blood serum digitalis level comes back and it shows that it is in the toxic range, then you are to hold their dig dose. Okay, you're not to give them their next dose of digoxin. Okay. And if it is in the toxic range, there is a sort of good news in the fact that we do have an antidote available to us. The antidote for dig toxicity is called Digibind. This medication will bind to the digoxin and it will form a complex that is excreted from the body. So all is not lost if they do develop this toxic dig level, and if they are at risk of developing arrhythmias, then maybe that you would administer the antidote per the physician's order. Okay, now we're going to talk about this term cardiomyopathy. It is a serious disease that affects the structural or functional ability of the myocardium. There may be multiple causes of this cardiomyopathy, including viral infections. Cardiomyopathy can be classified as primary or secondary. Primary cardiomyopathy can't be attributed to a specific cause. Secondary cardiomyopathy is due to specific causes. And when I talk about specific causes, I mean things such as high blood pressure, heart valve disease, congenital heart defects, and causes such as those. There are three main types of cardiomyopathy. They're classified as dilated, hypertrophic, and restrictive. And we'll talk about the symptoms, but some people who develop cardiomyopathy have no signs and symptoms, at least not during the early stages of the disease. But as the condition advances, signs and symptoms usually appear. This particular diagram shows a normal heart in the middle, and on the right we have a dilated cardiomyopathy, and on the left the hypertrophic cardiomyopathy. It's a nice diagram because it shows you the thickness of the myocardial wall compared to a normal heart. The dilated cardiomyopathy has enlarged chambers of the heart, and the myocardium is thinned and weakened. In a hypertrophic heart cardiomyopathy, we have smaller chambers and a thicker myocardium. First, we'll talk about the most common form of cardiomyopathy. It is the dilated cardiomyopathy. The heart cavity is enlarged and stretched. Cardiac dilation occurs. The heart is weak and doesn't pump normally, and most patients develop heart failure. Abnormal heart rhythms, called arrhythmias, and disturbances in the heart's electrical conduction also may occur. Blood flows more slowly through an enlarged heart, so blood clots may form. Thrombus can break free and become an embolus and travel in the bloodstream until it gets blocked in a small blood vessel. If the clot breaks off from, say, the right ventricle, it can be carried into the pulmonary circulation in the lung, forming a pulmonary emboli. On this slide, we see a list of all the many things that can lead to a dilated cardiomyopathy. On that list are two diseases that you are very familiar with, hypertension and coronary artery disease. But there are many other disorders that can lead to this dilated cardiomyopathy, including pregnancy. That's why we do find some young women who have heart failure, and it is often due to a pregnancy-induced cardiomyopathy. So the dilated cardiomyopathy, we said, is the most common. In fact, is greater than 90% of all cases of cardiomyopathy. It's characterized by an enlarged heart or cardiomegaly. We have ventricular dilation so that the ventricle wall is thinned. And this results in impairment of systolic function. In other words, contractility is reduced. This also can lead to the enlargement of the atria as well. As the blood doesn't flow in the correct direction, it backs up, causing enlargements in the atrial chambers. Again, there's that risk of stasis of blood and the formation of a thrombus. Dilated cardiomyopathies can also follow an infectious disease of the myocardium called myocarditis. Just as with heart failure, the interventions with cardiomyopathies are based on maximizing the quality of life. A priority goal is to improve quality of life, to reduce their symptoms, and so therefore treatment is more palliative. We can give medications to reduce their symptoms or to improve the efficiency of the heart as best we can. We do that by giving drugs like digitalis to enhance contractility, our ACE inhibitors to decrease afterload, and our diuretics to decrease preload. So we do work with our pharmacological agents to improve the efficiency of the heart. And in that way, we also reduce the symptoms, the shortness of breath, etc. Hypertrophic cardiomyopathy can result from conditions such as aortic stenosis and sustained hypertension. Sometimes it also is simply genetics. Okay? In other words, the patient may be born with a hypertrophic heart. In hypertrophic cardiomyopathy, the muscle mass of the left ventricle enlarges or hypertrophies. In one form of the disease, the wall or septum between the two ventricles becomes enlarged and obstructs the flow of blood from the left ventricle. And this syndrome is called idiopathic hypertrophic subaortic stenosis, or IHSS, and we'll talk a little bit about that in the next slide. So besides obstructing blood flow, the thickened wall sometimes distorts one leaflet of the mitral valve, causing it to leak. Hypertrophic cardiomyopathy is the most common inherited heart defect, and it occurs in about 1 in 500 individuals. Sometimes close blood relatives of these individuals often have enlarged septums, although they may have no symptoms. The disease is most common in young adults. So here is the other disease, another name that this is called, idiopathic hypertrophic subaortic stenosis. Okay, basically that's a big word for saying they have a big fat septum. Okay, the septal wall is hypertrophied, and that causes an obstruction, and it affects the outflow of blood. There is no ventricle dilation. It is, though, less common than other cardiomyopathies. It occurs more often in males than females, and it is the most common cause of sudden death in young people. Oftentimes it's diagnosed in young, athletic, and active adults. Often, the patient with hypertrophic cardiomyopathy is asymptomatic. Most common early symptom is dyspnea. They can also have fatigue, angina, and syncope. The symptoms include shortness of breath on exertion, dizziness, fainting, and angina, or chest pain or discomfort because of the reduced blood supply to the heart muscle. Some people have cardiac arrhythmias, and it is these abnormal heart rhythms that in some cases leads to sudden death. Okay. Okay, the least common type of cardiomyopathy in the United States is restrictive cardiomyopathy. The myocardium of the ventricles becomes excessively rigid, so it's harder for the ventricles to fill with blood between heartbeats. A person with restrictive cardiomyopathy often complains of being tired. They may have swollen hands and feet and may have difficulty breathing on exertion. This type of cardiomyopathy is usually seen in the elderly and may be due to another disease process. And so here on this slide we see a list of other disease processes and that can lead to this restrictive cardiomyopathy. At the top of the list is amyloidosis. Amyloidosis is the abnormal buildup of proteins in your body's organs, including the heart. Okay. Also on this list, you'll see post-radiation therapy. So if somebody is going through radiation treatments, it could result in the ventricles becoming rigid. The problem with restrictive cardiomyopathy is that rigid wall impairs diastolic filling and stretch of fibers. It doesn't stretch, so the contractility is lost. Many times we don't know what causes it. A good patient history will assist the care provider in ruling out other conditions and coming to the proper diagnosis of cardiomyopathy. Other diagnostic studies can be used as well to aid in the diagnosis, including a chest X-ray, EKG, and cardiac catheterization, as well as the echocardiogram. There is no cure for cardiomyopathies, nor is there a cure for heart failure. In fact, it generally just progresses till the end stages. Heart transplant is relatively common and is second only to kidney transplants. We have improved methods of preservation with the suppression of rejection reactions by means of modern drugs and also technology of the cardiopulmonary bypass machine or heart-lung machine, and also intensive care and wider application of heart transplantation in the clinical practice. It is the treatment of choice. Cardiac transplant is the treatment of choice for end-stage heart disease. Indications for having a heart transplant include a chronic ischemic heart disease, also cardiomyopathy with symptoms of severe heart failure. In fact, these are more than 50% of our heart transplant patients. And other heart defects as well can lead to a heart transplant, but less frequently than our cardiomyopathies. Not all patients who have end-stage cardiomyopathies or heart failure are going to meet the criteria for transplantation. Not all patients will be good candidates for heart transplants. They undergo a very thorough and complete physical exam with a full panel of diagnostic studies. Okay. The criteria for selection of recipients for heart transplantations includes satisfactory condition of the patient before the appearance of signs of the final stage of heart disease. In other words, the recipient must be a normal function in terms of their lungs, liver, kidneys, and central nervous system. As well, they should have normal function when it comes to emotional stability and interpersonal skills. This is a demanding process, and this will continue during the follow-up for the rest of their lives. So it is important that they have family support systems as well as motivation to follow through with that rigorous regimen. The recipient must not be actively developing an infection or any cancerous process or any severe vascular disease. Okay. When choosing a method of treating, the physician must be convinced that the heart transplant is the only way to prolong the patient's life, that all the other features or of other methods of treatment for severe heart disease have been exhausted before attempting a transplant. They generally say that heart failure, stage 4 heart failure, has a life expectancy of patients of less than 6 months. Okay, so when they're in that end stage of heart failure, they're really looking at less than 6 months of life. So there are many contraindications to heart transplantations, including if they have systemic disease such as insulin-dependent diabetes, or if they have a mental illness or chronic kidney disease. high blood pressure in the pulmonary arteries, which is called pulmonary hypertension. If they are markedly obese, have alcoholism or drug addiction, they would not be transplant candidates. Those that do make the list are usually waiting at home, hoping and praying. You can imagine the emotional stress involved, that a heart comes through for them. Although, because the process does move rapidly in the acute process, this patient also could be hospitalized if they are unstable. There are plenty of times when patients are in the ICU, and basically we're trying to keep them alive as long as possible with the hope that a heart will come through for them. Many times the waiting period is long, and many times patients will die while waiting for the transplant. If they are waiting at home, they need to be close to the hospital. They need to be within, I think it's 30 minutes to 60 minutes from the hospital, so that when they receive that phone call, that they can get there very quickly. Of course, they cannot just give them any heart. The heart has to be matched to them based on their body size and the heart size. Okay, so of course, the donor for heart transplant must be picked up by people with healthy hearts, possibly younger than 60 years, and with clinically established brain death. Donor and recipient must have the same blood group. In the blood serum of the recipient, it should not be have preformed antibodies against the donor lymphocytes or white blood cells. The donor must have a normal EKG and echocardiogram. And so we do have dimensions of the donor organ that must be close to the size of the heart of the recipient. Also, they would avoid cross-matching. They would not want to give a cytomegalovirus positive donor heart to a patient who is, or a recipient who is cytomegalovirus negative. Okay, that would not set them up for a successful outcome. The maximum time they have from the time that they remove the heart from the donor is 4 to 6 hours to get this transplant surgery completed. The recipient's heart is removed except for the posterior atrial walls and those venous connections. The patient after transplant surgery will take immunosuppressive medications. Some of them are listed here. Perhaps they'll be taking Imuron, corticosteroids, and cyclosporin are example of those immunosuppressant drugs. That's so that the patient does not reject the new organ. Every year, the patient will have to do a cardiac muscle biopsy. That's only a part of the picture, because in reality, the first year, they will have a cardiac biopsy every month for 12 months. Okay, how do they get that little piece of biopsy of the heart? Well, they have to go to the cardiac cath lab, and again, they'll go in through the groin all the way up to the heart to get that little biopsy. As far as the most common complication, it is infection, and that's a result of taking all of these immunosuppressant medications. When you suppress the immune system, the patient cannot fight infections well. And the transplant nurses at TGH have told me that a transplant patient owes them 1 rejection and 1 infection. Now, why would they say that? Well, if they have a cardiac muscle biopsy and it shows under the microscope that there is inflammation, that's an indication of rejection of the heart. That would mean that they need an increase in their immunosuppressive therapy. Now they would also like the patient to give them one infection. It doesn't matter where, just an infection somewhere. It could be a UTI, anything, but they need one infection because now they know that they should decrease the amount of their immunosuppressive therapy. And by using one rejection and one infection, they're able to get just the right doses of these medications. We need the right dose for that patient so that they do not get rejection and they do not continually get infections. Now, the sad news is that and the patients are aware of this, at least it's in the paperwork, that they are informed that they could develop cancer later down the road. Because when you suppress a person's immune system, that is usually what keeps our cancer cells in check or at a very low number. I mean, the bad news is we all have cancer cells in our body, but hopefully we have a strong immune system that keeps them really low. But when you are on immunosuppressive drugs, then you can't fight those cancer cells very well, and you can develop a malignancy. And indeed, that is one of the later causes of death post-transplant, is some malignancy. Frequently, it's a lymphoma or cancer of the blood. Another later cause of death would be coronary artery vasculopathy. Okay, so that those coronary arteries become diseased, and this can also impact their long-term survival after heart transplant. They've done some studies using angiography, and they've discovered that up to 40% of patients are found to have transplant coronary artery vasculopathy 5 years after transplantation. Nursing care for these patients involves promoting adaptation to the transplant process. Clearly, they are new to it. There are lots of new medications, new diets that they have to adhere to. There's so much involved in the transplant process that it is the nurse's role to keep the patient on track and to educate them. Teaching is a huge focus for the transplant nurse. They also will monitor and manage the patient's lifestyle changes.